And we asked Dr. Sangamitra to talk on retinal vein occlusions. Though the time given is 6 minutes, but I think if we speed up, it will be good for everybody.
Good evening. I would be talking about cataract with retinal vein occlusion. So we would be discussing on what should we watch out in the anterior segment. Is fundus evaluation important before cataract surgery? What if the fundus picture is hazy? Role of FFA and angiosity, and role of intravitreal, that is anti-VEGFs and steroids. As we all know, cataract surgery increases the arachidonic acid and prostaglandin pathway, thus increasing vascular permeability, leading to cystoid macular edema. Abnormalities in the superficial and the deep capillary plexus were common in RVO patients. Thus, patients with RVO would be more prone to the development of macular edema when compared with their counterparts without RVOs. So in the anterior segment, what should you look into? You should look at the pupillary reaction. This would give you a clue whether it's ischemic or non-ischemic. Look for NVIs and NVAs in the angles, and intraocular pressure, of course, because many of these are predisposed to have glaucoma. So how do you look for the NVIs and NVAs? NVI would be looking at the pupillary borders, the fine frilly vessels that are there. In the fundus evaluation, are dilated tortuous vessels with hemorrhages in all quadrants, a hyperemic disc, soft exudates, and macular edema would point out towards central retinal vein occlusion. Dilated tortuous vessels with hemorrhages in one quadrant would point out towards branch retinal vein occlusion, and both of these might lead to vitreous hemorrhage if they are ischemic. Now, this was the first case, was a 55-year-old female suffering from hypertension for the past 10 years, defective vision for 1 year. Best corrected visual acuity was 6/24 in the right eye. As you can see, there is an inferotemporal branch retinal vein occlusion with some amount of a suspicious new vessel like over here. So when we did the angiosity, we could see the new vessels over there with the adjoining CNP areas. So this patient who presented for cataract surgery underwent intravitreal injections along with sectoral PRP. So this was a 68-year-old female, again presenting for cataract surgery, a known hypertensive and diabetic for the past 12 years, with a defective vision for 6 months and intraocular pressures of 18 millimeters. Best corrected visual acuity in the right eye was 6/60. As you can see, there's a dilated tortuous vessels with macular dull foveal reflex. She had a CRVO with macular edema. When OCT was done, it showed a huge edema with loss of architecture of both the outer and the inner retinal layers. So when angio-OCT was done, it showed a gross macular ischemia both in the superficial and in the deep capillary plexus. Now this was again a 75-year-old female, known hypertensive for 10 years, had open-angle glaucoma on travertan. Intraocular pressures were 16, well controlled with anti-glaucoma agents. Best corrected visual acuity was counting fingers with the grade 3 nuclear sclerosis. As you can see, the disc was suspicious. There was open-angle glaucoma over there, and there was some anastomosing vessels in the disc margin. So when an OCT was done, it showed disc edema with traction over the fovea. Anti-VEGF, she was treated with the anti-VEGF agents, and post-anti-VEGF, there was a vitromacular traction. So she underwent cataract surgery along with vitrectomy. So role of anti-VEGF, you see, the risk of post-surgical CME in uncomplicated cataract surgery was 30 times higher if the operated eye had a history of RVO. This risk persisted even in eyes without preoperative macular edema. So patients with cataract who are actively managed for macular edema due to RVO with anti-VEGF agents may undergo cataract surgery. So this was my last patient, a 72-year-old male, a known diabetic and hypertensive for 10 years, had a history of stroke 3 months back. Intraocular pressures were 16 millimeters. Best corrected visual acuity was counting fingers. Again, grade 3 to 4 cataract was there, grade 3 cataract was there, and you see dot and blot hemorrhages throughout the fundus. So when an OCT was done, showed a huge macular edema. So as there was a stroke, already a stroke patient in the past 3 months, we gave dexamethasone implant. So intravitreal dexamethasone implant with phacoemulsification IOL implantation appears to be a safe and effective procedure for treating patients with concurrent macular edema and cataract. There was significant improvement in best corrected visual acuity and central macular thickness after surgery in this, as shown in this paper. So the take-home message is a thorough examination of both the anterior and posterior segment is essential before cataract surgery to both prognosticate the disease and to explain visual prognosis to the patient post-cataract surgery, to avoid steroids in patients with glaucoma, avoid anti-VEGF with recent history of stroke, or take a cardiological opinion, and OCT should be and is a must before all preoperative evaluation. Thank you.
Anybody wants to comment about it? I'll, in the meantime, request Dr. Vishali has to go for the presentation. Dr. Reddy, can she present? Thank you.
Sangamitra, what is your this advice for anybody who's presenting with, moderate cataract but with severe macular edema or moderate macular edema? Would you?
Then probably I would first go for anti-VEGFs or intravitreals and then go for cataract surgery if required, depending upon how much of cataract is there, whether the patient is going to improve after cataract surgery or not. But my first would be anti-VEGFs.
Would you prefer giving the injection intraoperatively during cataract?
So, yeah, we do.
Okay.
Thank you, ma'am. Dr. Vishali should be presenting on cataract with posterior uveitis, what to do.
Thank you very much. And sorry for jumping the queue as I have another talk. So the topic given to me is cataract and posterior uveitis. And to be very honest with you, this is the first time in my life I got this topic. Well, the points to consider. Is posterior uveitis a standalone posterior uveitis, or is it a part of panuveitis? Second, if it is a posterior uveitis, what is the phenotype? How good is the control of inflammation? Is there any concomitant CME present at the time when you take up the patient for cataract surgery? And do we have the definitive diagnosis yet? There are 4 situations which you would face as a cataract surgeon and retina surgeon. The situation 1 is there is cataract and there is active inflammation that includes vitreitis, and you don't have a definitive diagnosis as yet. Like this 69-year-old woman, you can see she has cataract and she does have some media haze and vitreous cells. The fluorescein here shows few pigmentary changes and some disturbances, but nothing to write home about. So this is the kind of the scenario where you would just do the cataract surgery, but you won't do only cataract surgery. You would also go and do the vitrectomy, clear the vitreous, and that vitreous that you are clearing will help both as a diagnostic and therapeutic. Because you don't have the diagnosis yet, so you would like to do cytology, mid-88, gene rearrangements, everything, as well as this is going to be a therapeutic thing for her. And for this particular patient, when we had the vitreous cytology done, she was diagnosed as lymphoma. Now you move on to the second situation that you have a cataract and you also has active inflammation, and that inflammation is treatable. For example, this patient here has complicated cataract, also has hypopyon and the inflammation which is very, very active. Don't ever think of cataract at this point of time. Just treat the inflammation or the infection, whatever it is. Like this patient had secondary syphilis with the features of condylometallata and corona radiata showing obliterative endarteritis, and he has cataract. So the cataracts honestly doesn't matter, and you should not be even looking at cataract. Just treat the infection, achieve a good quiescence over a period of 3 to 6 months, and only then go for cataract. The next situation is a child who comes to you with JIA, and this is a very typical situation that you have a child, complicated cataract, you may not be able to even look what is happening posteriorly, And these are the situations, never be in a hurry. These are the children, don't put IOLs, like be reported and all that, Ozurdex and all, but down the line, these are the children, do very aggressive management, 6 months of no flare and cell, and if you have laser flare meter, please go on that, do fluorescein, do the genetic workup, rule out all these syndromes, and then you manage it. So complete quiescence of the disease on biologics is extremely important. Don't plan any tapering if cataract surgery is in pipeline. Go on with pre-op steroids, intra-op DEXA implant, and very, very close post-op monitoring. Don't hesitate on dilators and cycloplegics. And the last situation is cataract with inactive heel scar. Don't even bother, just do the cataract surgery straight away, explaining to the patient with guarded visual prognosis, and I think peripheral vision has to be maintained. So I come back to my first slide again, the points to consider before you take up the patient. Is it a pure posterior or is it a part of panuveitis? What is the phenotype? How good is the control of inflammation? Is there any concomitant CME, and do we have a definitive diagnosis yet? Because that will depend on approach, whether you want to combine cataract with diagnostic vitrectomy, you want to wait, or you want to just do cataract surgery. Thank you very much. I hope I'm in time.
Very much in time, ma'am. Yeah, I'll request the chairpersons to ask the question.
I was just going to ask you, what if the cataract is dense enough for you not to, it precludes the posterior segment view. At that point of time, you can see the inflammation, but you're still not able to determine whether it's quiescent or, it's still active. So how do you decide on that?
So I would go with the previous history, because this is very rare that we come across children where they do not have, or even adult, where they do not have a past history of inflammation and only cataract, if that is the situation you are asking for. I would do an ultrasound B scan ultrasonography to look for how much opacities are there in the vitreous, to look for how much is the thickening of the retinochoroid. Because the active thickening of the retinochoroid on B scan means there is still active inflammation going on. But if the disease has been very long-standing and the choroid is actually showing atrophy, I will do UBM to look at the status of the ciliary body. If the ciliary body is showing the cyclitic membrane and atrophy of the ciliary processes, it again means it's a very long-standing chronic inflammation. So the day the patient presents to me is the day one for me. So I keep the patients, whatever treatment, immunosuppression, biologics, whatever the diagnosis, working diagnosis is. Every monthly, the patient is monitored for anterior chamber inflammation. If there are 3 months of quiescence of inflammation, we would take up the patient for cataract surgery, not on day one.
So one small question, ma'am. It's a panuveitis. Anterior segment has become quiet. You still have some vitreous opacities. You're not sure how much the activity is. If once the anterior segment becomes quiet, under steroid or biological cover, can you take up the patient for cataract surgery?
Yes, and I would do in such a scenario vitrectomy along with this, because I do vitrectomy for treatment of intermediate or posterior uveitis all the time. It reduces the need for immunosuppression and biologics. So if there are floaters and you think the floaters are going to bother the patient more after you have removed the cataract, you can combine the 2 surgeries together.
Yes, do you give Ozurdex every time or?
Not every time. Not every time. Only in situations like if it is a quiescent disease, VKH or others, we generally do not give Ozurdex. But if it is Behçet's, or if it is JIA, or if it is one of these Blaus and all, then we do give. But if the primary disease has been well taken care of, we do not give Ozurdex as a routine.
Okay.
Always. The positivity of vitreous sample will depend what you are asking for. So we don't send it blindly. For example, I showed that 69-year-old lady where I was suspecting lymphoma, so we will send for cytology, cytology always, flow cytometry if you have facilities, gene rearrangements, and the usual whatever. So the positivity will depend on your suspicion. Intermediate uveitis, by and large, do not show any positivity. Most of the time, inflammatory cells, and they respond to immunosuppressive therapies.
Thanks a lot, ma'am.
Thank
But
you.
Now that you have to go for the session, but please come back.
I
We
will.
need
Thank
your
you.
input.
Can I just ask one simple
Sure.
question? You avoided giving posterior subtenon triamcinolone.
Uh,
Those cases,
I don't.
you don't.
I don't,
So you
because I don't give anything in uveitis that I can't take back. With Ozurdex, I'm fine. If something happens, I go into the vitreous cavity and, chop it off. But for posterior subtenon, not really. But that is our centers. I'm not saying it's a good thing or bad thing, but that's how we
That is
practice.
the general policy also. Here, PST we avoid because, like she said, we can't take it
So
out.
we can't take
Suppose
it
patient
out.
has some issues, glaucoma or whatever.
Yeah.
It's impossible to take out the entire this thing.
I only
But
said
only
this-
thing I differ is we give Ozurdex virtually in all of them because
Okay.
because of the fear of
Fear
flare
of
up or whatever.
reactivation.
Especially if the NTS segment has been active or there are posterior seneca or whatever. Only isolated posterior uveitis you may not.
Irrespective of the stage at
Stage
which
of
it is
the-
in.
Yeah, if there is a component of anterior uveitis which was, active in my follow-up and then became inactive, now started cataract surgery, I will, because in any case, this will take care of post-op inflammation. In any case, these patients will have post-op inflammation. They will require, you said under steroid cover.
We generally, actually, we don't give because 6 months we monitor on flare meter, so we get a very tight pre-op. But if you are not very sure, sure enough.
Thank you, ma'am. And some
Thank
patients
you.
who cannot afford, I inject suprachoroidal because got
Yes,
some
suprachoroidal.
It's working pretty well. Yeah.
Thank you.
So thanks, ma'am. Next we have diabetic macular edema by Dr. Reddy. And the next speaker is Dr. Raja, who will be speaking on lamellar macular hole. इसके बाद Oh, okay. So IPCV. Oh, okay. Chal.
Yeah, good evening. Today I'll be talking about the coexisting diseases of both cataract and diabetic macular edema in a particular patient. Two diseases that we keep seeing pretty frequently and how we manage day in and out in our routine practices. Is the management of diabetic macular edema involves not only how to treat along with the coexisting cataract, but also counsel the patient the likelihood that they will develop a diabetic macular edema in the post-operative course. This is a very good study, UK DR, based on the electronic medical records, where they found that roughly the 6 months is the time when the incidence of diabetic macular edema increases following the cataract surgery. So this is an important piece of information that we should pass on to a patient during counseling. And irrespective of the stage of the diabetic retinopathy, no or mild, moderate, severe, the incidence of diabetic macular edema after cataract surgery doubles at roughly about 6 months post cataract surgery. And similar thing explained. And the management of these two diseases includes a good preoperative assessment that along with a good metabolic control and treatment of macular edema and the cataract surgery and follow-up. So the important thing is to grade the cataract along the extent of the cataracts, nuclear, posterior, subcapsular, depending on suitability for laser, and also grading the retinopathy and the macular edema, not just the macular edema, overall whether it is a mild, moderate, severe, or a proliferative diabetic retina, and relative contribution of these two factors in the visual loss of this particular patient. We should make sure that along with the macular edema, we stage the retinopathy, whether it is PDR is involved or no. We can see that the wide field fundus photography gives a better detail in staging the retinopathy. This is a lasered patient, and in the examination we can see that there are new vessels elsewhere. So we pick up new vessels, and this patient ideally need to be done a PRP before cataract surgery. This is again following a focal laser, presumably innocent, but we see that there are new vessels in other quadrants than we see. Yeah. The grading of retinopathy is important when we, in these patients, that involves detailed indirect ophthalmoscopy and also OCT angio if feasible to avoid invasive tests like FFA, and also look for undilated slit lamp evaluation in high risk PDRs to look for any early NVI or NVA. We see that most of the time they deteriorate into neovascular glaucomas soon after cataract surgery because of undetected new vessels. And it's better not to get fixated about central foveal thickness or central macular thickness, because some thick retinas see well, some thins don't. There are various biomarkers that one should actively look for in these patients, especially like derangement of normal retinal inner layers that indicates macular ischemia. As well as look for the outer horizontal outer lines in the outer retina that could indicate a photoreceptor damage, so we can prognostic a patient accordingly, and also look for interretinal interface disorders that probably will help in doing a combined surgery in these patients. OCT angio is very non-invasive and document macular ischemia that could help in prognosticating a patient of diabetic macular edema regarding the poor prognosis as well as probably poor response to intravitreal injections as well. And a good diabetic metabolic control before cataract surgery in high-risk individuals is good because that decreases the severity of the retinopathy, as we can see in this patient. And whereas focal laser, now coming to focal laser still has a role, especially in non-center involving diabetic macular edema. These are the patients once after cataract surgery, they could progress to a diabetic macular edema requiring intravitreal injection. So focal laser and non-center involving macular edema is good. And if there is a significant cataract, especially if the yellow laser with its properties of longer wavelength and less scattering, we can do a good PRP or focal laser in spite of this thick cataracts. Now, mostly the discussion will be on these kind of diffuse diabetic macular edemas, the treatment. Cataract in this treatment naive diabetic macular edema, the aim is to bring the central foveal thickness to less than 250 microns. I would prefer to give a dexamethasone implant and followed by cataract surgery after 3 to 4 weeks once the edema comes down to normal, and use anti-VEGF in case of established glaucoma or in cases on 2 or more drugs. This is a patient managed in a similar way, intravitreal dexamethasone implant followed by cataract surgery after 1 month. And then and DME, if the patient is on anti-VEGF injections and patient has a diabetic macular edema, I am a firm proponent that it's better not mixed at the time of cataract surgery, and mostly I advocate and follow this procedure. Best to plan cataract surgery 7 to 10 days after intravitreal injection, and idea is to bring the retinal thickness to less than 250 microns before cataract surgery, and then, and is the drug to be used for all steroid responders and PDR patients. And cataract patients, if there is a high-risk diabetic PDR with DME, if there is elevated FVP, it's best to give a dexamethasone implant followed by PRP at the 1 month after cataract surgery. Yeah, this is a patient of diffuse diabetic macular edema with cataract managed with anti-VEGF injections, and subsequently cataract surgery was offered to this patient. Now, combining cataract surgery with intravitreal injections, this is probably best avoided because there is no advantage, and it's always good to, and in case of any post-operative inflammations, infections, it's difficult to diagnose and treat, and nobody gains anything by combining these two procedures together ever. Yeah. And cataract surgery patient, one should keep in mind that it's better to avoid pre and post-operative antibiotics because you're likely developing resistance to this bacteria, and if at all you're very keen, better not use quinolones, or you could use some other antibiotic which has a lower profile. And during cataract surgery, anticipate slightly higher risk of inflammation or PC rupture in this kind of patients. And this I would like to thank my colleague Dr. Dipender for this slide. And the risk of PCR following injections is high following dexamethasone implant, and higher chance of retained lens material and increased end-off following dex implant. The patient. cataract surgery being performed after intravitreal Ozurdex injection, PC rent being managed without. Sen? This is basically after intravitreal injection when cataract is being done, develop PCR.
This is for cataract surgery being done after multiple anti-VEGF injections.
Yeah.
Odds ratio was high.
Thank you.
No, that one video.
I'm just saying that these particular group of patients are more likely to have PC ruptures during the cataract surgery.
That was a nice article actually. It's a high odds ratio.
But I mean, why are you against cataract surgery? You said patients on injection avoid this surgery.
So come again, sir. Simultaneous.
Because patient will always thank the cataract surgeon, not you. Then I'm telling you, because this in practice this dilemma occurs. You keep treating retina, so you refer for cataract. He is thankful to him only, not to you at all. So always.
Because ideally, I feel.
Because you people, I don't do cataracts, but you people, young people, can do cataract and both. So I will, because patient visual improvement generally will occur, by 2-3 lines post cataract surgery. So you'll also be thankful.
No, the point Dr. Lalit is raising is if the cataract is significant. That's the
obviously.
point.
I'm not talking of 1, 2, 3.
So we know a lot of patients where the cataract surgery does not result in visual improvement also. So when not to touch that.
No clinical advantage of giving them together unless you are giving a prophylactic injection to take care of edema which is not there.
No, can you show the third, fourth slide, because you said cataract surgery.
Yeah, that's what I advocate, and mostly not do, because I think it's unless there is any specific benefit, because patients are anyway used to taking monthly injections. For them, compliance of it's not like combining phaco and vitrectomy where
We keep giving injections. He goes to some other surgeon who is a general ophthalmologist. He will do cataract surgery. Dr. Sahab, उन्होंने ठीक कर दिया.
So that.
We are giving injections to control macular edema
Yeah.
before cataract surgery. If you are doing injection at the time of surgery.
I'm not saying give at the time. I'm saying what I'm saying is keep the patient with you and do cataract surgery.
Yeah. Of course. That's
No, but would you ever give at the time of
no, that's
cataract
what I meant was at the time of cataract surgery, never give an intravitreal injection.
So there was a study from PGI where they gave Ozurdex and all the cataract surgeries.
No, they are probably. I generally don't subscribe and I don't advocate that.
I had a question. Do you agree to the premise that the cataract surgery would worsen the progression of the diabetic retinopathy severity?
Yes, I think there's enough literature shown that it almost doubles the risk of diabetic macular edema. Yeah.
My question actually is that do all the cases actually progress, or there are certain cases which have a higher HbA1c levels which are operated with a normal FBS and a PPBS?
I think likely the
an
ones that
article-
progress are ones which have probably worse control.
Anything more than moderate, they do progress. Mild. And,
This is the study that shows that in all grades of retinopathy, incidence doubles following
So
cataract.
the next question actually is, does the retinopathy progression and the maculopathy progression, are they together similar or are they different? The question is whether the progression that we are talking about.
Yeah, I think what we have enough is about maculopathy progression, not diabetic retinopathy does not progress in the 6 months' time. It's the edema that progresses worse after cataract surgery.
Answer that. I think I actually did a very interesting study. I presented it,
I think there's a DRCA.net protocol which has said that if you have macular edema, so if you do not have a macular edema but you have a non-proliferative diabetic retinopathy, go ahead and not do cataract surgery, it will not progress.
Correct.
But if you have a macular edema with NPDR,
This is where I was coming from.
then you can do cataract surgery, then maculopathy, that's what he's saying. If you have maculopathy, it will progress.
No, the question actually is the progression matching the progression of the maculopathy, and suppose there is also...
No, probably it doesn't match. Diabetic retinopathy does not progress so fast. Diabetic macular edema is the one that worsens
See,
after cataract.
early phase, if there was no pre-existing, I would look at Irwin gas more in the early phase.
Ashish, can you please?
No.
Thank you.
Thanks. Sir. So Ashish is talking on Lamellar, macular hole, epiretinal membrane, and I think cataract surgery.
Second last. Pointer. At the outset, I would like to thank the AIOS, and it's wonderful to be back here in a physical setting rather than just online where you can't really interact. So I think this is my second talk after the thing has started. So I'm going to talk today on cataract and epiretinal membrane and macular hole. So it's important that we have a high index of suspicion whenever we see such patients. Whenever there's a mismatch between the grade of cataract and the visual acuity, one has to be sure that there is nothing wrong with the macula. So you have to see importance of symptoms of central scotoma and metamorphopsia. There are some patients who have cataract but they still complain of metamorphopsia, and in these patients you must do a pre-op OCT. You can also do a slit lamp biomicroscopy with a non-contact or a contact lens. There's a Watzke-Allen test. However, the OCT takes preference over all these things, and most of these patients have to be subjected to a OCT pre-cataract surgery. Now, if you see on the OCT, there is a progression of the holes which are there. However, lamellar macular hole can remain stable over a period of years, and nothing sometimes may need to be done. Sometimes there are epiretinal membranes which are found on a routine examination, and even in these patients, the patient's vision is good. So again, nothing needs to be done. So when we see these patients, you have to assess the degree of the macular hole or the epiretinal membrane. One has to see whether there's progressive visual loss, which is accompanied by worsening of the hole or worsening of the macular edema. Lamellar holes usually do not progress. Full thickness holes usually have to be operated. If there's increasing macular thickness with traction, then definitely the ERM also needs surgery. And it's very important that you rule out other causes like parafoveal telangiectasia, diabetic macular edema, and CNVMs. Because sometimes through a cataract, your fundus view may be hazy, and one needs to do OCT and sometimes even a FFA if they get some good pictures in order to differentiate between these conditions. The next thing is you need to assess the degree of cataract. The most important question is, does the cataract need surgery if there was no hole? And is visualization good enough for an ILM peel? Once you have assessed this, then you decide what to do. There are three options. You can do cataract surgery first and macular surgery later. You can do cataract and macular surgery both at the same time, or in patients in whom you can see enough to do an ILM peel, you can do the macular surgery first and then do the cataract surgery. Let's see about each of these things. Cataract first and then macular surgery. If there's doubt about the status of the hole, sometimes you have a small lamellar hole, the patient doesn't need surgery. Patient has significant cataract, go ahead and do the cataract surgery. In a lamellar hole, cataract surgery would improve the vision. ERM patients who do not have thickened macula or traction again will improve with the cataract surgery only. And sometimes patients are unwilling for retinal surgery. They have heard that retinal surgery is very difficult, you need to keep your head down, etc., and they just want cataract surgery, see how much the vision improves. But in all these patients, you have to say that we will have to do the surgery in 2 sittings. First stage, do the cataract, and then if required, do the macular surgery also. Here you see a patient who had significant cataract. However, there's a small outer lamellar hole over here. Patient doesn't need to undergo macular surgery. We do only the cataract surgery. Look at this patient. This patient was advised a combined surgery in one of the big institutes. And when we saw her, there was a little epiretinal membrane. I thought that the patient would not need a retinal surgery. This is 2017 picture. This is 2020 picture. We did only the cataract. The ERM is absolutely stable. Patient's vision has improved from 6/18 to 6/6 partial N6. Patient is an 80-year-old housewife. Patient is happy without doing the retinal surgery. So if you feel at any stage that if you only do the cataract and the patient's vision would improve, do the cataract only. The next thing is single sitting cataract and macular surgery. This is essential if an ILM peel cannot be done. If the degree of cataract is so much that you can't do ILM peel, you will do it. It reduces the surgical time. There's a faster visual rehabilitation. However, wound leak chances are increased with prone positioning. There are monetary and insurance issues. Whenever you do a combined surgery, you give the bill for cataract with a vitrectomy, the patient always gets reimbursed only for cataract, and that to a very minuscule amount. So this is the problem which we have with insurance patients. There's also an ethical dilemma. Your cataract surgeon colleague has referred the patient to you. Should you be doing both the surgeries, or should you refer the cataract surgery back to him? So this is the ethical dilemma which we face in private practice. So when you do combined surgery, you always do the cataract first. You have to avoid corneal edema, miosis. any air bubbles in the viscoelastic. So at all times, you should have a good view of the retina. You also avoid multifocal IOLs, and you ensure a tight, good watertight closure of the wounds, because afterwards the patient has to lie in the prone position. In the post-op period, wound leaks are common. There is more inflammation in these patients. There sometimes is a small streak of blood on the corneal endothelium. Because of the air bubble, the IOL can get displaced, and dilatation may not be possible in the initial stage of the disease because you have put a lens also. However, multiple studies do not show any increase in hole closure rates or complications, but visual rehabilitation is definitely faster in combined surgery. Then you do macular surgery first and then sequential cataract surgery. This can be done only if ILM peel is possible, which means that the cataract is very minimal. The patient is not willing for cataract surgery. Sometimes you have a young patient, a 40, 50-year-old patient with a macular problem. Why do you need to do a cataract surgery at the same time? Head-down positioning is safer and there are lesser chances of wound leaks. There's a better chance accuracy of biometry. If there's a macular edema, a significant edema, your biometry can go wrong. So once the edema settles down, your biometry is better. Again, you have monetary and insurance issues because you're doing one surgery, then doing the second surgery. In the second surgery, there would be zonular compromise because now you're doing surgery in a vitrectomized eye. Sometimes it has been reported that macular edema post-cataract can open up the hole, and there's always a posterior capsular plaque. So in sequential cataract with vitrectomized surgeries, there's a very dense cataract, and often a dense brown nucleus, just 2 minutes. There can be zonular compromise, anterior chamber fluctuations, lack of vitreous support, and a higher chances of fluid misdirection. In all these patients, there is a posterior capsular plaque, and you always need to warn the patient about it because after the cataract surgery, the vision will not improve. You may need to do a YAG laser later on. I just skip this. And so, there is a large study which has come in ophthalmology retina in November 2021, in which they compared combined versus sequential phacoemulsification, and there was no difference in post-op best corrected visual acuity. The combined surgery had more fibrin and synechiae and intraop and post-operative retinal detachment. However, there was a lower incidence of posterior capsular tear and macular hole non-closure or reopening. So with this, the jury is out. You can do either of these things, whichever you are comfortable. They all give rise to approximately the same result. Thank you.
Any questions to Ashish? I think a monetary issue is important because if you do together, then एक का पूरा मिलता है, एक का half मिलता है.
Yeah, exactly. That's what. So that is very important.
And if you are doing ERMP later on, the person has had a cataract surgery, patient's vision has improved, patient may not require, as you rightly pointed out.
But there are patients, especially younger patients with, like you were showing one case where that 80-year-old lady, suppose you have a traction and then many of these patients complain of metamorphopsia, post-cataract surgery.
Definitely.
So that could be an indication for...
Yeah, so in these patients, you have to warn the patient that you will need a sequential surgery. Yeah. And also in these patients, I think you need to wait for if you feel the edema is not significant initially, you need to wait for 2 to 3 months for the post-operative edema to settle down. So only after the post-operative edema settles down, you will be in a position to judge as to how good the vision is.
Very true.
Thank you.
Thanks, Ashish. So next we have Dr. Sarvanan. Is he here? No, he's not there. And we'll Dr. Rajanaran will be talking in IPCV.
So, good evening everyone. Once again, I would like to thank the organizers for giving me the opportunity to present on this topic, which is not actually listed, but there was some confusion, so it's a last minute that I have digged out this presentation on PCV. I would like to thank my fellow who also actually had an important role in managing this case. So, I would be discussing a little bit about how PCV is diagnosed, what are the treatment modalities, but overall this session is about role of cataract surgery, how to decide cataract and retina as cause of vision loss. So we have been debating whether we should do both together, one first, second, what should be the sequence. But first of all, we should be clear whether cataract is there or not, and whether there is retina problem or not. That should be absolutely crystal clear. If there is no cataract, but again, how do you know whether there is cataract or not? I'll come to that. There are a few guidelines. It doesn't require artificial intelligence. It's natural learning. The 62-year-old gentleman presented vision loss, 10 days, and no history of trauma, ocular surgery prior. But 10 days history of vision loss, someone says sudden. Cataract is insidious. Patient will not say since yesterday my vision loss or 10 days. We generally ask, is sudden vision loss usually a different cause? This patient was diagnosed with PCV and submacular hemorrhage 12 years ago, had received multiple injections, PDT. On examination, vision in the left eye is 20/30 and 12. But now I will come to the point. As a comprehensive ophthalmologist, that means we may be doing cataract, we may be evaluating retina also, sometimes we can manage medical retina cases also, we may be doing injections also. So if we evaluate cataract, one eye is 6/6, there is already a comparator eye. So if you do a torchlight examination, let's say above the age of 60, everyone is going to have cataract. There is going to be some opacification. But you cannot decide cataract surgery based on torchlight examination. The first thing, if you ever are deciding cataract surgery decisions on torchlight examination, it's a no-no. Please stop doing that. You must have a slit lamp evaluation before you advise any cataract. The other thing is, as I was saying, there is a normal eye. In this patient, right eye is normal, 6/6. Assess the lens status in the 6/6 eye. Assess the lens status in the blurred vision eye and see if the cataract is same or not. You don't need an LOCS at that point of time, a graph to compare, but the normal eye vision is a good comparator by itself at that point itself. So if the cataract is the same, either the nuclear sclerosis, there is no posterior subcapsular cataract, it's all the same, and one eye is 6/6, other eye is let's say 6/9, 6/12, whatever it is, the answer is straightforward, that there is probably some other cause for the vision loss. I mean, I am just teaching here step by step why, whether cataract is there or not. Looks very basic, looks very simple, but sometimes we just misjudge based on a particular, let's say torchlight examination and say you have cataract. But even otherwise, with experience, cataract surgeons also start knowing that this kind of cataract is not explaining this vision. Many experienced surgeons would say, okay, this lens to me looks like more like 6/12 to 6/18 kind of vision. Why is this patient having counting finger vision? That's when you start evaluating the retina or optic nerve very carefully. The other way to do is, let's say if you have taken a fundus photograph, look at the clarity of the photograph in both eyes. Is it the same? Is there any hazy view in one eye which may be accounting for the vision loss, which could be cataract? If not, if the clarity is the same, look at other pathology, macula, optic nerve. There this patient is obvious, in the left eye there is a subretinal bleed, subretinal fibrosis, right eye is PED. This is a multicolor imaging. What about OCT? Obviously, in all of these cases, all the speakers earlier have shown OCT. If there is any doubt, you must pick up OCT. I don't want to go into details of management of PCV, as this is not the appropriate forum for that. But yes, this patient has a PED and subretinal hemorrhage. We did ICG, it shows a nice branching neovascular network and polyps. And this patient has, by definition, a cataract, but it is not the operable cataract. It's not the cause of the vision loss. So you don't have to do a cataract surgery in the left eye. The left eye subretinal hemorrhage, 10 days history. Cataract is similar in both eyes when we had the comparing it with the normal eye in the right eye, and obviously in the fundus photo clarity was similar, and we picked up. So management option, this eye doesn't need a cataract surgery. And these are the different options. I don't want to go into brolucizumab, but we gave one injection and there was some improvement. Subretinal hemorrhage was still there. I'll go straight to the ICG over here. At 6 months, there is some regression of polyp. And 1 year after the overall injection, that is 6 months after the third brolucizumab, you see the subretinal hemorrhage has gone away. There's no PED here. ICG also shows no polyp, and the OCT is also much better. This patient is maintaining good vision at this point of time. So this is the sequence of OCT and ICG at presentation, 6 months, 1 year, and then this is the OCT at various time points. So I would like to conclude that we have enough tools in our own clinical skills, right from our ophthalmology, PG, residency, MS, DNB, what we are doing, that is what needs to be applied. And if we are good in that, we will not have this debate about what should I do, who should take the credit for better vision. Sometimes we have cataract surgeons doing cataract surgery when the retina has major problem and a disgruntled patient comes to a retina person. And the other way around, what Dr. Lalit was saying, a retina surgeon is keeping on giving injections, and retina surgeons also miss cataracts, right? It's not always the other way around. Cataract surgeons may miss retina problem, but retina surgeons also can miss cataract. And then the credit goes to the cataract. Either way, look at the patient as a whole. Whole patient has to be treated by us, either by alone or in collaboration with our colleagues. Thank you so much for your kind attention.
Thanks, Dr. Rajaswa. Any questions?
Raja, you continue giving injections, but sometimes, in between the patient gets a cataract surgery done outside because, out of the institute. Sometimes it happens too, and then they come back to you post that with the cataract done. So those situations also happen. So you need to
absolutely.
warn the patients on that.
Yeah, so I don't mind if someone gets a cat, as long as it was indicated and it was not unnecessary. And we have a frank discussion with the patient beforehand itself.
So 1 minute, I'll ask you a question. Dr. Mudit has to go, so he'll be presenting, and Dr. Shantanu Mandal is here. So maybe Mudit he'll... So I have a question for you. Since you were giving brolucizumab with IPCV, and that can cause some inflammation, cataract also can cause inflammation. So do you give a gap between...
Yeah, I would give usually 3 months gap is from my experience. There's no guideline on that.
Yeah.
IPCV, brolucizumab can cause inflammation, but at this point of time, we know how that inflammation occurs, after how many injections. It's not immediate the first day after injection. You don't see, those are not the typically reported brolucizumab inflammation. Usually 2 weeks after the second or third or fourth injection is when you see that inflammation, whereas if cataract surgery is done, you will have an immediate inflammation. So those are some differentiators, but your question, there is no level 1 evidence. I would still keep a gap of 3 months before the two.
Thank you. Dr. Mudit.
All right, so good evening once again, and first of all, I would like to thank the chairperson and all the panelists of this session, and also to the All India Ophthalmic Society for giving us a chance to speak upon this. Now, what I'm going to basically talk about is cataract with macular problems. Is my pre-op protocol correct? And now, basically what I will be talking about is something which has already been dwelt in detail by the earlier speakers. Dr. Raja Narayanan just right now mentioned that we have to look at the patient as a whole. We tend to sometimes forget or differentiate ourselves into either we are cataract surgeons or retina specialists or oculoplasty or whatever. What we tend to often forget is that we start as ophthalmologists. That means we are supposed to take care of the entire eye, not just focus on the logistics of cornea or cataract or retina in person. So whenever you see a patient, there are a few things about what is your pre-op protocol. Now look at the systemic parameters of the patient. Is the patient an uncontrolled diabetic or not? What's happening to the systemic conditions of the body? When you are evaluating a cataract, obviously it makes sense to look at the zonular status of the lens, because if there is a zonular weakness, you are probably having a risk of the lens getting dislocated. There will be refractory surprises if we don't look at these points or factors, if we don't keep them in mind while we are evaluating your patients. And therefore, like any other evaluation for any pathology, not only in eye but any part of the body, take a meticulous history. correlate vision, look at the retina. One of our earlier speakers, Dr. Vedya, just said it makes sense to correlate the vision and see if the lack or the discrepancy in vision can be accounted by the cataract. If that is the case, it's good enough. But if you have got a cataract which is not commensurate with the amount of vision loss, it makes sense for even otherwise to keep in mind that there may be something else which you are dealing with. And therefore comes the part, what we are supposed to do for every patient, a comprehensive, complete ophthalmic evaluation, which includes best corrected visual acuity, a meticulous slit lamp evaluation, look at RAPD. If there is any neovascularization of iris or angles, obviously it makes sense to look at that. IOP, fundus examination. In cases apart from our clinical skills, sometimes we may need to resort to using ancillary investigations like an angiogram, OCT, or in cases where you can't visualize the retina because of the fact that you've got a very thick, dense cataract, a B scan if needed in those cases. So we have already had some talks in this session which have dealt about macular edema, epiretinal membranes, possibly vitreomacular traction is something which we'll deal with in diabetes. These are points which you need to keep in mind, and therefore let me show you some cases where the patient was initially referred apart from cataract, and when we saw the patient, we saw this was a patient who had a macular hole. Now, because of the fact that there is a macular hole, obviously, if you go ahead and only do a cataract surgery, sometimes you may end up with a suboptimal visual outcome. So these are points which you need to keep in mind apart from this. Another patient who was referred to the retina services with a cataract, but apart from the cataract, when you do a retinal evaluation, you see these pigmentary changes and a vitreomacular adhesion. This was a patient who, apart from having diabetes and hypertension, also had parafoveal telangiectasias. So you may see retinal pathologies which may probably compromise on vision. Another case which shows how important it is to do a complete evaluation. So this was a patient referred to the clinic with a vision of 20/40. But when you look at the retina, what you see is a sub-ILM hemorrhage and a white-centered hemorrhage. This was a 41-year-old male patient referred to the retina clinic. And when we did an OCT, we found this sub-ILM hemorrhage, and there was a single white-centered hemorrhage. When we investigate the patient systemically, what we found was blast cells and myeloblasts. This was a patient of a known case of CML, which we were able to pick up because of the fact that we went ahead and investigated what a single white-centered hemorrhage. So this basically highlights how important a good complete evaluation is as part of our clinical evaluation. Apart from that, what you also need to keep in mind are any inflammatory pathology. So this was a patient with cataract, but with multiple diffuse fine stellate KPs, no CME, no synechiae. This is a case of Fuchs uveitis. So again, these are cases whom you need to counsel for the fact that you may still have some vitreous opacities in the eye. You may have a risk of IOP elevation before you go ahead and do a cataract surgery also in these cases. So when you see multiple fine diffuse KPs in a patient who predominantly might have a posterior subcapsular cataract, no CME or other obvious signs of inflammation, Fuchs may also be one of your differentials. Apart from that, look for any sequelae of any post or old uveitis. So in cases where there is a uveitis, you may need to ensure that the eye is quiescent for at least 2 to 3 months before you go ahead with a cataract surgery. So these are some of the points. I know this may sound repetitive, but these are actually supposed to be a part of a complete evaluation for any of our patients, not just for cataract. One more patient, now this opacity which you are seeing, this is basically because of dense posterior polar cataract which the patient has. And this patient also has these pigmentary changes in the eye and a lesion over in the superior temporal quadrant. This patient was actually referred to us thinking it's a uveitic pathology, but what you also need to look at is look at the other eye. The other eye had a pachychoroid. So that was a patient with a scar subsequent to PCV and peripheral subretinal heme. So it makes sense to look at both eyes of the patient, do a complete meticulous ophthalmic evaluation, and that should be a part of your pre-op protocol. So take a history, correlate vision, and a complete ophthalmic evaluation, and that should complete your pre-op evaluation for all patients. Thank you.
Thanks, Mudit. Thank you so much. We'll call Dr. Shantanu. Yeah. And speaking on CSR. After this, Dr. Abnenda.
Good evening, everybody. So, again, a controversial topic, cataract with CSR, what to do. Yes. So, central CS here, fourth common cause of retinopathy. After AMD, diabetic retinopathy and branch retinal vein occlusion. Typically occurs in males between 20 to 50. No underlying pathophysiologic mechanism till date have been proven. It's thought to be to occur due to hyperpermeable choriocapillaries with RPE functions. dysfunction. Recurrence rate is 31% and first recognized by von Graffe. So etiology, exact mechanism, though unknown, but many associations found. Steroids, both endogenous and exogenous. This is the strongest known association. Type A personality, release of glucocorticoids during stress, increase in choroidal vascular permeability, which leads to microribs in RP, H. pylori infection, MDMA or ecstasy, along with sildenafil topiramate drugs, sorafenib and vemurafenib, the anti-cancer drugs. These are all associated and reported with CSCR, and increased sympathetic activity along with obstructive sleep apnea. These are the associations we found in literatures. Common risk factors: pregnancy, alcohol use, untreated hypertension, obstructive sleep apnea, depression, Cushing syndrome, SLE, organ transplantation, end-stage renal disease. So these are all common risk factors. In one study by Sai et al., published in 2013, there is male preponderance between the age group of 35 to 54 years. But in between 55 to 59 years, there is a second peak of CSR, which shows that there is male-female equal, 0.21% and 0.2%. After photorefractive keratectomy and LASIK, there is a report that few cases of CSR after 4,800 consecutive LASIK and PRK cases. This might be due to extensive topical corticosteroid use, elevated cortisol level from stress of surgery, mechanical disturbances after excimer laser, LASIK fabrication in susceptible patients. There is another report in IGO that acute central serous chorioretinopathy following subconjunctival triamcinolone acetonide injection, less drop approach. So in this series, there are 3 cases of CSCR noted, 0.26% out of 1129 eyes. All 3 patients shows pachychoroid features on enhanced EDI-OCT. So preoperative EDI-OCT might help in identifying these patients who are prone for developing CSCR. So keeping these things in mind, we have 2 questions. What to do in this macular problem if associated with cataract? So if the patient presents with cataract and has a past history of CSCR, question 2, if the patient presents with cataract and has a neurosensory detachment at presentation. So I have found one article. This is published in Korean Journal of Ophthalmology in 2021 June. So this is a small group of patient retrospective study. This shows the short-term outcomes of cataract surgery in patients with a history of central serous chorioretinopathy. This study shows that significant improvement in visual acuity was noted after uncomplicated cataract surgery in eyes with history of idiopathic CSCR, regardless the presence of SRF. A definite increase in retinal thickness or recurrence of CSCR noted in only a limited proportion of patients. Further studies are required to identify whether the cataract surgery has a long-term influence on the clinical course of CSCR. Keeping this paper in mind, I think we can answer the questions. If a patient presented with significant cataract and has a past history of CSCR, no NSD, neurosensory detachment found in the pre-op OCT, cataract hinders the vision in case of old CSR, cataract surgery after proper counseling. Proper counseling means that there is chance of recurrence. If possible, in pre-op EDI OCT, if we can see that there is a pachychoroid, then we can also explain the patient that, see, you have cataract, but you have a chance of recurrent CSR. And post-op topical steroid for 45 days didn't show any significant recurrence of neurosensory detachment by this study. Question number 2, if a patient presented with cataract and has CSCR at presentation, significant amount of cataract with neurosensory detachment, FFA not possible, EDI OCT possible, then we have to go for EDI OCT, and cataract surgery after proper counseling with minimum post-op steroid. Pre-op FFA possible, shows leakage, treat the leakage, wait for NSD to resolve, and go for cataract surgery after proper counseling that there is chance of recurrence. Pre-op EDI OCT, suggestive of pachychoroid vasculopathy, then treat accordingly, and pre-op steroid for 45 days didn't show any significant recurrence of neurosensory detachment. So these are all about patients. What about surgeons? So there is one study which shows that the ophthalmic surgeon, this is published by Ahmad M. Mansoor, that CSR of the left eye at initial visit, follow-up OCT scan, 5-6 years OCT scan serials, OCT scans are there. And these are the conclusions, that resolution of CSR after 3 to 4 weeks of occurrence, but the recurrence induced by stress in the operating room. The available evidence suggests that those overcommitted surgeons, type A personality, may very well be most susceptible to burnout and central serous chorioretinopathy. So please, thank you. Nothing more I have.
Sorry. Yes, you're next.
Good evening, everybody. First of all, I'd like to thank convener. My teachers are here, and I'll be talking about cataract with macular problem, what to do and when to do in cases of choroidal neovascular membranes. I'll skip the initial part, and I'll try to answer these 4 questions which is there in the mind of all anterior segment surgeons. First question is, does cataract surgery worsens choroidal neovascular membrane? The answer is big no. So what does the literature suggest? AREDS-2 study, that is age-related eye disease study 2, mentions that the participants in the study were evaluated for up to 10 years, and after cataract surgery, a mean improvement of +4 and +11 letters in AREDS-1 and AREDS-2 studies were there. That means there was a significant cataract, and after doing cataract surgery, the vision improved. The participants who had cataract surgery showed no increase in risk of AMD progression versus those who did not. The same conclusion we derived in Marina and Anchor trial. And in one of other study, cataract surgery leads to vision improvement and does not appear to contribute to worsening of age-related macular degeneration. And there are ample number of literature available which says that cataract surgery does not worsen CNVM. The next question comes, when should you do cataract surgery? The surgeon should decide whether cataract is hampering the vision or not. If you have a central cataract, you should go ahead and operate this patient. If there is a dense nuclear sclerosis, it tends to decrease the contrast sensitivity. So these patients should be taken up for cataract surgery. Central cortical cataract should also be taken up for cataract surgery. But before cataract surgery, as my previous speaker, Raja, Dr. Ashish, everyone has mentioned that screening of OCT should, screening of macular disease with OCT is a must. And there was a study in which we have done OCT before, and the result of that study was the management of 107 patient out of 411 patient was modified. OCT finding which were either missed in 22.8% or underestimated in 3.2% by fundus bimicroscopy examination. So OCT is a must in these kind of cases. The third question comes, when should you do cataract surgery? If cataract with CNVM is diagnosed at presentation, first treat the CNVM with 3 loading dose. Once the lesion becomes dry, then you can go ahead and do the cataract surgery. Cataract surgery should be avoided within first 6 months of the treatment. If the lesion does not dry up, simultaneous cataract surgery with anti-VEGF can be planned. And what we do is we give anti-VEGF once we have inserted the IOL, and we don't do a viscoelastic wash and inject because the eye is hard at this moment. Once the injection is given, after that viscoelastic wash is done. The third question is, how does it helps the patient of age-related macular degeneration? The first thing is it increases the contrast sensitivity, thus helps in reading vision, also improves the BCVA and peripheral vision, thereby helping daily activity. It decreases glares and improves color vision, thus helps in the quality of life indices. In a recent study, identified the risk of fall, which decreased by 54% once the one eye was operated, and other eye, once the second eye was operated, the disease of fall was reduced to 73%. It improved the visual acuity and contrast sensitivity, and there was a decrease in number of falls. The fourth question which comes in mind, which IOL to choose? So unifocal or aspheric IOLs are the best in cases of wet AMD. Toric IOL do not compromise with contrast sensitivity and can be used in patients of age-related macular degeneration. Multifocal IOL should be avoided as it decreases contrast and has higher order aberrations. Evidence of EDOF IOLs are well tolerated in patients of AMD would be required before advocating them. So to conclude, cataract surgery does not worsen the AMD disease process. OCT scanning is a must before taking patients for surgery. Cataract surgery should be done after 6 months of initiating the treatment. Simultaneously, cataract surgery and anti-VEGF can be considered. There is an improvement in BCVA and contrast sensitivity, which improves the quality of life, and multifocal IOLs should be avoided. Thank you very much for your kind attention.
Thanks, Abhinanda. I think that was an important message, that cataract surgery doesn't worsen ARMD disease. That means a good cataract surgeon, if you're given a injection, you don't have to wait for 3 months for it to dry up, or can you because the cataract surgeon says, "Jaldi karo, let's operate the cataract."
See, if it is diagnosed on onset, you should dry up the lesion and do the surgery after 6 months. That's what the literature recommends. If the patient is on a follow-up and is on treat and extend protocol, then...
But in your setup, if Mahipal is he wants to operate cataract...
No, that he doesn't. Because the problem is, the brunt will come, patient will come and tell, I didn't get any benefit from cataract surgery. And then it will come to the retina surgeon, you manage.
So wait for 3 injections and dry up.
Wait for at least 3 loading doses and at least the macula to dry. And you should be able to counsel and convince the patient that yes, after doing cataract surgery, you will have a definite improvement in vision. Because after 6 to 8 injection, you develop a kind of relationship with the patient. And this relationship will help you to counsel the patient what time you should go in for cataract surgery. But the important thing here is, don't go for any premium IOLs, go for the basic unifocal IOLs.
How long do you wait before, when the CNVM has dried up, how long do you wait before you decide you can now safely go ahead and do the cataract surgery?
Sir, if I feel the cataract is enough and it will give a visual benefit in terms of contrast and vision, I'll go in for cataract surgery right away.
Thanks,
Especially in posterior subcapsular cataract, nuclear sclerosis, it benefits a lot.
Next we have Dr. Preetham talking to us on post-operative CME. And just to ask whether Dr. Anindya Kishore Majumdar is here. Dr. Manisha is here, I can see. Dr. Vishal Kishore. Yeah, okay. Dr. Vishal, why don't you come in front? Yeah, thanks.
Yeah. Many thanks. It's great to see everyone in person again. Yes. In fact, I've been telling people we're meeting after a long time, don't wear a mask. I hope the authorities don't catch me for that. I've been discouraging people to wear a mask.
Aapki authorities.
Exactly, I'm the LOC. So, I'm going to talk on post-operative cystoid macular edema. So, what is CME? CME is the retinal thickening of the macula due to disruption of the normal inner blood retinal barrier. This causes leakage from the perifoveal capillaries, retinal capillaries, and accumulation of fluid within the intracellular spaces, mainly the outer plexiform layer. What happens is the visual loss occurs from retinal thickening and fluid collection that essentially distorts the architecture of the photoreceptors. Like this, you can see over here the edema primarily in the outer plexiform layer. Symptoms, the patient will present with decrease in visual acuity. It's of a gradual painless nature. Loss of contrast sensitivity, color vision, there'll be metamorphopsia, micropsia, and central scotomas. These are the usual symptoms. It is popularly also known as Irvine gas syndrome, essentially an inflammatory process which occurs in about 20% of eyes following cataract extraction, much lesser with the recent cataract methods of phacoemulsification and flax. 1% of those affected have clinically significant decrease in visual acuity. The incidence is more in those cases where you have a PCR, a posterior capsular rent. It occurs mainly, presents about 6 to 10 weeks post-op, and 95% of Irvine gas resolves spontaneously, mind you. Only 5% will actually require aggressive treatment. Now, what you have to be careful of is concomitant problems when you're dealing with a post-op CME. Like you could be having a vein occlusion over here which will look like a CME on OCT. So be careful about these. The clinical diagnosis, you can make it on slit lamp biomicroscopy. On color fundus, when you're looking at, you'll see those intraretinal cysts around the perifoveal region. So it will look something like this. If you watch closely, you can see some cysts over here. But what will clinch the diagnosis, you can do fundus fluorescein angiography. In the early phases, it will show capillary dilatation in the perifoveal region, and in the late phases, what is classically described as a petaloid pattern because of the Henle's layer at the fovea. But routinely, we don't do fundus fluorescein angiography. The OCT is what normally is done to demonstrate. It nicely demonstrates the cystoid macular edema. The OCT also helps to show if there is any concomitant vitreomacular traction, epiretinal membranes existing along with the cystoid macular edema. Now, you have to also keep in mind the other differentials. I showed this slide before. It could be a macular BRVO, so make sure you're not dealing with one. There could be concomitant vitreomacular traction or epiretinal membranes. The other differentials which can masquerade as cystoid macular edema can be parafoveal telangiectasia, or juvenile retinoschisis, chronic central serous retinopathy, or even CNVM, especially of the RAP lesion variety. These all could mimic like CME. Management, cystoid macular edema can be managed medically most of the times. It may require surgery only if there are concomitant pathologies. So managing the etiology again will depend if there is a ERM or vitreomacular traction. Usually it is self-limiting and NSAIDs do the job. If the CME persists, then you may require topical steroids or periocular steroids. So I usually prefer to start the patient on ketorolac or nepafenac or bromfenac. And if it does not respond within about 3 to 4 weeks, then I use topical steroids, either prednisolone or difluprednate. One has to remember that you have to keep secondary glaucoma in mind when you're putting the patient on topical steroids. Injectable steroids, when, like I said, if there is no response to topical steroids in about 4 weeks' time, then I will resort to injectable steroids. I usually prefer giving intravitreal steroids. If the patient is affording, then my choice is giving an intravitreal dexamethasone, Ozurdex, or I choose intravitreal triamcinolone. You can also give a subtenon's triamcinolone for cystoid macular edema. Again, the red signal is look for secondary glaucoma in the ensuing days. Now you can see a patient here. This was just last month. You can see the date here, 7th of May, just last month, came with post-op CME and a subtenon steroid, and 2 weeks later you can see how the CME comes down drastically. From 620 microns, it is down to about 400 microns, the central retinal thickness. So it responds quite well to the periocular steroids. Surgery, when there is associated epiretinal membrane or vitreomacular traction, then you will do a vitrectomy, you will peel the membranes, you will do a posterior vitreous detachment, and that will give you good results with the CME resolving. So to conclude about pseudophakic CME, it is an important cause of mild, painless loss of vision post-cataract. OCT is very important to diagnose, prognosticate, and follow up, a non-invasive tool. CME is usually self-limiting and spontaneously resolves within about 3 months. Resolution of edema may be helped by the medical and surgical treatments which I highlighted. And mind you, the chronic, it needs to be treated because chronic edema over time may lead to permanent photoreceptor damage with retinal thinning and fibrosis. Thank you. If time permits, maybe if we can have a discussion on whether anti-VEGFs and the role of CA inhibitors. I just put that slide. Thank you so much.
I think, the hall moderators are asking us to finish faster. We started a session late, so no questions. We will go on to the next speaker. Dr. Ananda Kishore Majumdar is not there, so I'll request Dr. Manisha to talk on premium IOLs and macular diseases. And then we have the last talk by Dr. Vishal Kishore. Yeah, he's there. Dr. Manisha has activated the Haryana Ophthalmic Society very actively. She's doing great work.
Yeah.
With regards to the chair, and good evening to all ladies and gentlemen here, I start with my talk, that is premium IOLs and macular disorders. All the macular disorders have been explained very nicely by the speakers before me. So I now tell what should we do when we have premium IOLs with us. And to begin with, I would say all that glitters is not gold. So today's intraocular lens technology, it benefits from the ongoing innovations. Eye's natural ability to accommodate and refocus at varying distances in a pre-presbyopic eye is matchless. Premium IOLs give patients more independence from glasses than ever before. Premium IOL technology, it refers to IOL biomaterials, aspheric design, and special refractive properties. Advanced surgical techniques and these IOLs, they have significantly improved the post-operative visual outcome. We know the various premium IOLs, multifocal IOLs, toric multifocal, accommodative, MF IOLs, and as said, EDOF types. So multifocal IOLs, they provide spectacle independence for near, intermediate, and distance vision. The concept was given by Hoffer in 1983, and Pierce in 1986 gave the first bifocal IOL implantation. Toric IOLs correct the corneal astigmatism and give spectacle independence for distance vision. The toric multifocal IOLs, they offer spectacle independence, especially for the corneal astigmatism. Accommodative ones, without giving any additional spectacle correction, gives good vision for clear vision at near and distant focal points. It produces a dynamic increase in the dioptric power of the eye with accommodative effort. Position is changed, shape-changing IOLs are there, and refractive index modulating accommodative IOLs are there. So a tricky situation is there when there is an IOL. We have to decide in a case of a macular disease. So how we go about it? Macular diseases, we all know, they are associated with decreased sensitivity, contrast sensitivity. So multifocal IOL implantation could result in further reduction in contrast sensitivity. Hence, there is poorer vision than with the monofocal IOLs. Macular diseases like ARMD or diabetic retinopathy that progresses with cataract surgery. The significant or progressive macular pathologies, there are a contraindication for multifocal IOLs. In those cases, special implantable IOLs can give us a good vision, and the focus can be on the normal retina, not on the scarred retina or the macular disorder where it is present. It's a combination of convex and the concave lenses. Double optics are there. It is implantable. They can give some good vision in these patients. So toric and multifocal IOL implantation, it compromises the visualization of the macula and optic nerve post-operatively, so we should avoid. So premium IOLs should be best avoided in these pathologies. ARMD or diabetic maculopathy, it progresses after cataract surgery, and the diagnosis and treatment is adversely affected due to these premium IOLs. Preoperative OCT should be done. Significant or progressive macular pathologies like retinitis pigmentosa and Stargardt's disease, They are the full-fledged contraindication for multifocal IOLs. So what if there is a history of macular diseases in the family? If there is a history, strong history, these patients are normal. They can be considered as normal. Hence, all the IOL technologies I talked of can be offered to the patient. Counseling on the potential problems of multifocal IOLs should be told to the patient. Proper counseling is done, and they can go for any of these IOLs. But if it is an early maculopathy, like there is a soft drusen, or if there is a pigmentary change at the macula, and with relative sparing of the Sneller's visual acuity, they are difficult to counsel. There is loss of contrast sensitivity at lower spatial frequencies. So even in mild forms of AMD, which affects the quality of life, it is plus minus whether we should go for this IOL or not in early maculopathies. Better to avoid. Implantation of a multifocal IOL is a relative contraindication. IOLs that tend to decrease the sensitivity are avoided. In cases of moderate macular disorders, in AMD cases, where there is drusen, geographic atrophy, or exudative change. And if we think that monofocal or toric IOLs, as the benefits of accommodating IOL would not be appreciated, avoid them. So in advanced cases of macular disorders, where there are large scotomas and poor macular function, poor visual prognosis is there. The use of intraocular magnifiers, they are there, which can be used in such cases. Avoid the premium IOLs. So what is the key? The keys to success with these premium IOLs? Careful patient selection and pre-operative workup is of paramount importance. We need to talk to the patient, counsel the patient. Once again, I emphasize, clear communication should be there. Proper education regarding realistic expectations are the keys to success. Select your IOL judiciously in macular disorders. Selection can give a satisfied patient, otherwise a frustrated patient forever will be there for you. Thank you.
Thanks, Dr. Manisha. So take home is monofocal lenses?
Yeah.
And,
monofocal, if there is early, very early, or there is a family history, then it is plus minus. You can give the plus and minuses of these lenses to them, like photopsias and glare would be there, and difficult to examine if the disease progresses. It is the patient's choice. Otherwise, if it's a moderate or severe AMD, no.
So EDOF lenses would work well here?
Yeah, sometimes, yeah.
So why not toric?
Toric, basically, they are only for astigmatism, for correction of the astigmatism. Yeah. It can be given as the previous talk. Yeah. In the last talk, it was said that toric IOLs, they are safe. What I had read as it was given, no, not to give even toric IOLs.
But that's
I was having this query.
A monofocal toric rather than a multifocal toric.
Yes, that is.
So thanks, Professor Manisha. Thank you for.
Thank you so much. Thank you.
We'll have the last talk by Dr. Vishal. He's talking, is my post-op protocol correct? And it's wonderful that so many people are staying back, so thank you.
So good evening everybody. Being the last speaker, I won't take much time. So coming to my talk on, is my post-operative protocol correct for patient undergoing cataract surgery who is having previously remains having a macular degeneration? Now, why so much extra care and protocol for these patients? We all know that cataract patient means anyone who is undergoing cataract surgery, we cause iatrogenic trauma, which starts a cascade of inflammatory reactions. And these patients with retinal pathology, they themselves have an eye which is compromised and inflamed. So a vicious cycle starts. So we should have a rigorous protocol for patient preparation, surgical technique, and post-operative control, which can help to minimize the risk of complication and achieve a good post-operative outcomes. Now, next question is, will the cataract surgery increases macular degeneration? Now, we have a discussion on this in the previous talk, so won't spend much time on this. Actually, some studies had suggested that wet AMD increases, but after large population-based study by ERETS-2, which evaluated the patient for 10 years, they conclude that there is not much change, means there is no change in the incidence related to cataract surgery in AMD. So, the most important protocol pre and post surgery is the counseling. We all know all over the world, whoever is undergoing a cataract surgery, there was a high expectation Post cataract surgery means high expectation regarding the vision. They have a concept of like bang vision or what we call jackass vision. But we have to downplay this expectation. We have to assess preoperatively what amount of cataract is responsible for the vision loss and what amount of macular pathology is responsible for vision loss. And accordingly, we have to counsel the patient and decrease the expectation. We have to even counsel them that since you are having cataract, we haven't assessed your retina properly, so post-surgery we'll assess it, and maybe you may require photocoagulation depending on the pathology and the lesions, or anti-VEGF, or even you may require secondary this VR surgery. So you have to counsel them properly and give more chair time. That is the most important post-operative care, even pre-operatively. Next area of concern, like where we will deal in our post-operative care, is like there are some studies have suggested that there's slight increase risk of acute and delayed end-op in patient undergoing cataract surgery who had previous intravitreal injection or any other VR surgeries. Then second area where our care will be regarding anti-VEGF injection. And third, patient with severe macular degeneration whose vision is not improving, we can go for low visual aid like lighting magnification and reading aids. So since coming to this increased risk of acute and delayed end-op, we have to follow strict and over-suspicious post-operative vigilance in these patients with a history of intravitreal injection undergoing cataract surgery. This is the key to success. Now coming to intravitreal injection, means we have seen that there is no change in the schedule of intravitreal injection in patient with AMD pre and post cataract surgery. So the schedule will be same as it was before the cataract surgery. But eyes with suspected or confirmed macular membrane or cystoid macular degeneration or macular edema or other macular pathology, some retina surgeon recommends that you have to give intravitreal injection 2 to 4 days before surgery or immediately after the end of the surgery. But in this scenario, you have to have a good retina backup because you have to deal in case of severe inflammatory response. Then some suggest to give anti-VEGF on PRN basis, that is as and when required after 1 week of surgery. While few people have a suggestion, you can inject slow release intravitreal drug implant like Ozurdex or Retistud to control the inflammation. And in case of diabetic retinopathy, as the media clears, you can assess the fundus properly and then you can decide on either you are giving anti-VEGF or panretinal photocoagulation or secondary surgery. Likewise, means after you properly assess the fundus. And in patient who is having a severe macular pathology and whose vision is not improving, we can ask for low vision aid, which is more beneficial once the media gets clear post-surgery. And this portable, nowadays modern portable electronic devices have desirable properties such as flexible use of magnification. So to summarize, rigorous follow-up is essential to minimize inflammation post-surgery. And routinely this patient are put on topical steroids and NSAID, which is given for at least 3 weeks. But in this patient having macular pathology, we continue this NSAID treatment at least 2 to 3 months post-operatively, and we routinely examine the patient. And in patient who is requiring anti-VEGF, ideally we can give on PRN basis 1 week post-surgery or 1 month after post-surgery, and we can follow the patient in the retina clinic. Thank you for the patient hearing.
Thanks, Vishal. That was a deadly cat. Thanks. Any questions from Dr. Vishal? And otherwise, thank you all very much. We had a lovely session. We did speed up a little bit. We also benefited from some dropouts. And I think everybody is waiting for Shan to come. So, thank you. Thanks a lot. Thank you to all my chairpersons.
Thank you, sir.
Let's have a small picture. All the speakers, everybody.